Can I see that Professor Chan and also Luca are here. Maybe I'll ask our colleagues to bring them all to the panel. So to the floor, I congratulate the around 30 participants who's still around. So please do share with us any questions you have. We have an excellent panel to try to answer your questions or to discuss any issues you may have. While we're waiting on questions, maybe we can start the discussion. I see that all three speakers and also probably in Hong Kong as well. Prince of Wales Hospital, where I worked, was very hard hit, and one of the earliest affected hospitals is in Hong Kong. And at that time, I can still remember we had colleagues who had fallen ill from SARS and who had to be admitted to ICUs. I was just wondering, hoping to maybe ask our three speakers, what sort of precaution had been used for protecting your staff? I mean, PPE is definitely one of the things that has been mentioned, but I was just wondering whether you had, dirty teams, different rostering, whether that's something that has been adopted in your departments. Maybe Professor Chan, you can share. Do you have dirty teams or do you have special roster for people who's taking care of fever or suspected COVID patients? Professor, you're muted, so.
Yeah, sorry.
Yeah.
Just as I mentioned in my presentation, because we have quite clear policies in screening and risk classification for emergency department patients as a patient with symptom compatible with COVID-19 infection or with risk of epidemiological exposure. This patient will be considered as a high risk of the contracting COVID-19 SARS-CoV-2 virus. So in the management of these patients, our doctors have to wear a high specification, well complete PPE, including the N95 face mask, gown, and gloves. So this patient should be treated in outdoor ED with a high requirement of the PPE. But in contrast, for general patients without risk of the COVID-19 infection, so this patient will be treated as usual care. We only wear the surgical mask and not necessary we use the gloves except we have to physical contact for physical exam. So I think this is the best way to allocate for the best use of our PPE. So I think this is our policy in Taiwan.
Christian, can I just follow up on that? Do you have designated staff always taking care of suspected cases?
Yes, in our emergency department, we have one specific team, including one ED staff and one nursing staff, specialized for screening and do the sampling sampling of the patients with suspected COVID-19 patients. So you will be working in a specialized outdoor fever screening station, and just it's different specialized work and for the manager of the screening of these patients.
Great, thank you, Christian. Thank you. Can I go to Mikkel with Denmark? Did you have specialized teams?
As I said, we had a lot of time to discuss at the beginning because we had no patients. So we had a lot of meetings about what we should do. And we discussed every option we could come up with and troll through the internet to see what other people have done. In the end, we decided to stick with our routines because we knew how they worked and we knew what to do. So we basically saw any patient, any of the team, except if we had staff that was pregnant or were at high risk, if they became infected themselves, they were relieved from seeing COVID suspected patients. But otherwise, we saw them routinely in any room by any team member that was on the floor today. We basically in the beginning isolated everyone and then started to get to understand the disease and know the disease, and then started isolating a bit more intelligently and used PPEs a bit more intelligently. But we definitely kept every resus patient, so everyone going to one of our trauma rooms, were handled as COVID until anything else was known. So we put on full protection for those because we had no time to dress up if need be. We used the same rooms. We had thorough cleaning, of course. And now we've switched, so we'll see suspected COVID in any room. Again, if you're high risk or pregnant, you wouldn't be allowed to see them. And then once we know they're positive, we transfer them to a small unit within our unit where they are handled by as few staff and also with a very strong focus on hygiene as well. It seemed to have worked. We've had, I think, only 1 or 2 staff contracting COVID on the shop floor. Otherwise, it's been all the few we've had positive have been positive elsewhere, usually during their vacation when they were out away from us.
That's good. Yeah, thank you, Michael. Luca, what about you from your side? Just want to hear your thoughts because I think you are the ones at the front line there.
Yeah, thank you very much, Kevin, for involving me in the discussion. So from my experience, what I can highlight is that the most important issue at the beginning in Italy was the coordination between hospital and pre-hospital settings. So even I don't want to talk about a specialized team, but I would like to talk about the importance of coordination among different sectors. And here in February, during the first wave, we had a lack of this important coordination, and most of the patients were brought directly to hospital, and the workload of the hospital was too high to deal with. So, and the problem was because the pre-hospital care and the family doctor system were not aware and coordinated in the right way to manage and to mitigate the influx of patients. And after the first month, we have implemented a specialized team in the pre-hospital setting composed by family doctors that were focused on COVID patients and with the specific home treatment. And this was a key to reduce and to mitigate the burden in the hospital. And this was what we experienced during the first wave. And because, for example, since Italy was the first Western country hit by the COVID-19, everybody were talking about ICU, the importance of ventilation, and so on. But in our opinion, with our experience in disaster settings, in humanitarian context, we right away highlight the importance of other aspects of the response. Again, especially to equip all the healthcare workers, not only in the hospital, with basic principle of infection prevention and control measure and basic principle of surge capacity, disaster medicine, and to facilitate the understanding on how to coordinate pre-hospital settings and hospital setting. And in fact, during the second wave, we were a little bit much prepared, even though the second wave was, and also the third wave is still very, very heavy. In any case, we learned from the first experience, and now we are much more coordinated between the sectors. You are mute, Kevin.
Oh, I'm still muted. Sorry. Thank you, Luca. I was just saying we have a couple of questions coming in, but just wanted to maybe follow up with you, Luca, because of your experience. We've seen in New York and in other places that there are healthcare workers, because of the stress and the workload. We've seen self-harm. We've seen colleagues who died from COVID, and there was a heavy mental burden. I was just wondering, in your experience, whether how do you enhance resilience, and perhaps what can we do to make sure that we're not burnt out, or we're not too stressed? Luca, I think you're muted.
Sorry. In my experience, since the beginning, was to make the physician, nurses, and all the care workers aware of the situation. Again, nobody experienced such a crisis before. And nobody at the beginning were understanding exactly what were happening, okay? To reduce and mitigate the stress and the mental distress, what we did was, during this training that we ran in March, and also we are still continuing to run this training in the hospital, was to continue to make them aware that we are in a disaster. So we are responding a huge disasters, and your intervention and your daily activities is a key to save life. And when they understood that it was not a normal situation or something that to complain about, but when they felt involved and they felt important for the response, so their mental status changed completely. And I have some colleagues that at the beginning were scared and they were not willing to respond. After this understanding, after explaining them the situation, and also I explained what I experienced during the Ebola response and how much was important their activities and their involvement, they change a lot the perspective. And from being scared to the most important professional working every day. And this experience was from the first wave. Then we experienced how to maintain and continuously maintain this mental status. And what we are doing is refresher courses and changing shift and try to involve more healthcare workers, even though the newly involved healthcare workers have no experience before. So refresher courses, just training again new physicians to change and to have new, fresh physicians and nurses working in the COVID-19 treatment to reduce this mental burden.
Okay, thank you, Luca. I see that Professor Chen wanted to ask a question.
Yes, thank you. May I ask Professor Brandon one question? Actually, I'm pretty interesting about you analyze the ED patients' visits during the period of COVID-19 in Denmark. You analyze the patient number of acute myocardial infarction, acute stroke, or even trauma patient. I think that in addition to the case numbers, did you try to analyze the quality of care of these patients about, for example, acute stroke, acute myocardial infarction patients during the period of COVID-19 pandemic compared to the pre-pandemic era of these patients? And thank you.
Sorry, that's a very good question. Thank you. No, we haven't done it yet. We have tried to do our own analysis about stroke, but we have a very strong stroke database in Denmark, and we haven't been able to replicate their results yet. So we kind of lost out of stroke, but we're looking into STEMIs and to ACS care, but we have very little data in our databases on treatment. The only time points we can look into are EMS services, so call for help, pick up, delivery to hospital, and we just had that data on Thursday last week. And then we got the times from the cath lab with the STEMI and time to balloon and stuff, but we've been waiting for the data from the EMS system. So hopefully within the next few weeks, we'll start to look into the quality, because that is very important. And of course, that's a big worry. And that's why I went into this about looking into COVID. What happened to all the other patients? Because for COVID, of course, based on your experiences and especially the one from Italy, had all the focus, and we were worried, and I worried about what would happen to all the other ones that lost out of national interest. So it will be there, but it's going to be a while.
Okay, thank you. I'm looking forward to your further analysis about the quality of care of these patients. Thank you.
So thanks, Michael. Maybe I can just start asking some questions from the floor. One of the question was maybe relating to the health systems. So there is some question regarding whether emergency department is tasked with the task of testing for COVID. Just wondering, in your system, whether patients come to the ED for suspected COVID and for testing, or whether it's done in other primary care settings, for example, and whether there are any lessons learned from that. Maybe to start with you, Michael.
Okay. In the beginning, we had very few tests available nationwide. So it was centralized in Copenhagen, and everyone who was tested, the sample had to be driven to Copenhagen and analyzed. And therefore we had a capacity problem. However, very soon the government contracted with some of the big Danish companies like Novo Nordisk, who has a huge test capacity and a better understanding on how to scale tests, and suddenly they could test enough patients. And then we could test everyone, and very quickly, in the beginning you had to be sent by your GP for a test. Very quickly you could basically go on a website and order your own tests, and then you had your results delivered electronically as well. Now it's open. You can go out, have a lateral flow test in 15 minutes all over the city, all over the country. So it's completely open, and that's why we've done so many tests. Now yesterday we did 181,008 PCR tests and 186,702 lateral flow tests in Denmark. So it's very open now.
Wow, very precise. Thank you, Michael.
I have it on the screen.
Great. What about Luca? Maybe to you. Do you test patients? Don't have to come to the ED for COVID tests, I presume, for Italy.
No. So we have several ways now to test for COVID, but now normally is done at the pre-hospital setting. So family doctors and are allowed to also pharmacy, so store for pharmacy for drugs are meant to do COVID test, and also there are private health facility that are providing COVID tests. So now the amount of COVID tests done in the hospital is very low, and only for the patient that are coming to the hospital.
Thank you, Luca. Professor Chen, maybe if I can ask for your experience in Taiwan as well, and then perhaps a follow-up question as well.
Yeah, yes, at the very early beginning of the pandemic outbreak, actually we have a very limited the testing capacity for COVID-19. But right after that, our country expands the testing capacity to set up in many hospitals. So now we can test the COVID-19 infection the test in many hospitals. And but even though we expand our testing capacity for COVID-19, we have focused on two kinds of patients. The first is the patient with risk of the COVID-19, especially the epidemiologic risk. And the second for patient with the highly suspicious or even mostly for community-acquired infection, especially for community-acquired pneumonia, we can test all the patients to rule out the possibility of the COVID-19 infection for every patient with community-acquired pneumonia. So this is our policy for now, so we can have the best use of our precious testing capacity in our country. Yes.
Thank you. And if I can just share the last question in view of time for the panel. Professor Chen, can I ask you, you talked a little bit about telemedicine in your emergency department. The audience was just curious whether the telemedicine is within the hospital or whether you see patients using telemedicine in their community, outside in their home as well. Which modality was used, or was it both?
Yes, actually, we so far we just used the telemedicine in emergency department for patient screening for COVID-19, and as you know, it's difficult and it's impossible to use the telemedicine to care about the severe COVID-19 patients in the hospital, because you have to many physical or physical therapy, or you have to check the physical exam with the stethoscope. So we just use the telemedicine in the emergency department. We use it so we can minimize the duration of our staff to exposure to the patients. We can check history and obtain the necessary information by telemedicine, just using in the emergency department. So we only use our doctor only needs to contact the patient when necessary. If you want to, if our doctor have to take the samples from the respiratory samples from the patients, and we emphasize actually there's no worry about the care of the quality, and no worry about the patient certification. I think it's pretty good for emergency department to use the telemedicine in the screening of the patient with risk of COVID-19.
So the patient would still have to come into the emergency department, right? Okay.
Yes, yes, yes.
Can I ask Michael, maybe you can respond about telemedicine in your department as well?
We haven't used telemedicine, frankly, at all in my unit. However, GPs have, and they see the majority of patients in a walk-in or in their own clinics, out-of-hours clinics. And when you call this clinic today, they can send you a link through your smartphone, which opens the camera, and then they can do the consultation through video, so with the patient at home. This has completely changed the way they work. Usually they had where I live, 14 doctors at night driving around seeing patients at home. That has now been reduced to 3 simply because of the use of video instead. They look down people's throats with the video and see whatever they can see and try to diagnose based on that. It's not always perfect, but it's definitely better than exposing them to the risk.
Great, thank you, Michael. And Luca, maybe your experience in the field hospital or in your department, whether you use telemedicine.
So we in Italy we have been using telemedicine in the pre-hospital setting, mainly GPs. The network that I said before, when in February we started to have this network of family doctors working specifically for COVID-19 patients, we have implemented a telemedicine system where the patients are assessed and also continuously assessed by telemedicine system, and it's still continuously working. In the field hospital, we haven't implemented such a system. We were only coordinating between hospital and field hospital without improving, adding challenges to an already challenged situation. So there were still difficulties in moving patient and in coordinating patient between hospital, and therefore we have not implemented any telemedicine system.
Thank you, Luca. That's great. So before I hand back to Colin for his closing remarks, I'd like to thank all of you, Professor Chan, Mikkel, and Luca, for your sharing. I hope that the situation will continue to improve when we all get vaccinated, and hopefully we can again learn from each other and improve our preparedness. And I think Tremedim is doing a lot, and I think there's a lot we can learn from each other and the statistics and what's being shared. So again, thank you all for your participation, and look forward to seeing you physically sometime. Thank you.